Hello, good evening.
Hi.
Hi, this is Dr. Santana. This is Dr. Tom Nabby. We're from the Michigan Center for Regenerative Medicine. Thank you for joining our webinar tonight. We're happy to have you. So tonight's topic is actually really interesting and close to Dr. Nabby's heart and back.
It's fine.
Yeah. So we kind of wanted to talk about the sequence of events that kind of led to Dr. Nabby with his back pain issues and how we treated it with orthobiologics and kind of go through that experience. So just to kind of give patients the idea that, hey, we believe in these procedures so much that we would do them ourselves, to our families, to our loved ones. So it kind of gives you the confidence that this is really something that we want to do for everyone, right?
Yeah, it's something we truly believe in to the point where if we have ailments that arise, we're patients as well. We have nagging injuries and pain issues, and anytime that John's needed something done, he's leaned on me. Anytime I've needed something done, I've leaned on him. And most recently, after about a year and a half of progressive back pain that was getting to the point where it was causing me problems on a daily basis, I decided to move forward with a stem cell procedure for my spine, and fortunate enough to have the best in the business working with me here, and was able to have him perform a procedure on me in early December. So we decided not to talk about it before I could speak to whether it was helpful or not. And that timeline is usually right around 3 months where people can tell a difference or not.
Yep.
So that's here kind of to share my experience thus far and being on the other side of a needle and what it's done for me in my life.
Yeah. So it's funny when you approached me with this idea back in November, right? I thought you were just joking, because you're a pretty active guy. You exercise every day, you hike, you run, you bike, you do all these things, and then you play competitive golf. So it's you're a very active individual. When you came to me that you're kind of exploring this option, I was actually surprised. So tell me more about kind of what symptoms you were feeling, when did it start, and kind of what made you decide that, hey, maybe it's time to do something about it.
Yeah, never had a back issue my entire life. I can honestly say I don't think I've ever had my back go out, even during college playing basketball. Any of those high competitive sports, never really fortunate enough not to have any major injuries. 2018 was out hiking in Colorado, and with my brother and another business partner of mine, and we got 3/4 way up the mountain. My back went out. I didn't have to be carried off the mountain, but almost had to be carried off the mountain. And ever since that episode, I just, I got that one to resolve with rest and stretching, and I just thought it was a mechanical thing, a muscular thing. It had to be a muscular thing. And I can exercise my way through it, and I really worked on my core. I went to physical therapy. I got a good set of exercises that I was very diligent about doing. And boy, the pain just wouldn't go away. Tried a couple trigger point injections, tried to do them once on myself, which didn't go so well. But the pain was lingering. So eventually broke down and got an MRI and shared that with you.
Yeah. So look at the MRI. It's surprising, like for somebody who's so healthy and stuff like that. But you kind of do see it, with activity, wear and tear as you get older. There are some changes that you see, and mostly degenerative changes in there. So just a description of your MRI. So Dr. Nabby did have some degenerative discs in the lumbar spine, primarily L5S1 and L4, L5, with some herniations on there. Not too severe, but enough to kind of cause symptoms. There's also what we call modic changes that we see on the MRI, where the vertebral bodies are showing some changes in inflammation and edema around where the vertebral bodies are, which are the bone segments. So we had that discussion, kind of the best way to approach it, and it was actually your idea. You've tried a lot of things for it already, a lot of conservative management, the same things that we would probably talk about when somebody comes in with back pain. Try the conservative management first, exercise, stretches, physical therapy, yoga, core strength, all that stuff. And then you move forward to the more aggressive treatment as you kind of not fail those types of treatments. So, but because we are in the regenerative medicine space, we have that capability here, and it's readily available. So we decided why go through the whole rigmarole with doing steroid injections and blocks when we know that regenerative medicine and orthobiologics works really well. Rather than just putting a Band-Aid on the pain, let's just fix the problem at hand, right?
Yeah, pain. It is. I tell my patients, and I feel like I live by it too. Pain is a privilege. It's your body saying something's wrong. And I tried everything I could think of outside of a surgical procedure to fix this and manage it without taking medications, without injecting myself with pain alleviating medications. And the next step in that algorithm of treatment is a orthobiologics regenerative procedure.
Yeah. So for this case, we've talked about doing PRP, which is platelet-rich plasma, and bone marrow stem cells. So there's good evidence on both sides of the camp as far as using PRP versus stem cells. We're kind of more in the camp when we're treating degenerative disc that we kind of like using bone marrow stem cells more for many reasons, and that's why we decided to jump over and decide that's a treatment course that we're going to do for Dr. Nabedy. So we kind of got everything set, got all our ducks in a row, and scheduled for the big day. Yeah. Right? Did you do any preparations before the procedure?
Yeah. So the same preparations we recommend our patients take: supplements, oral supplements with primarily high doses of multivitamins that you take. There's some senolytics. The one we typically use here is called quercetin, but fisetin would be another one that would be a good substitute. That helps weeding out the cells that are less energetic or less potent to really harness in on those cells that you're getting out of my bone marrow being the most potent. And then I did a little extra and moved into this world of peptides. In particular, so peptides in general are hormones, but they're shorter amino acid sequences. So we call them peptides instead of hormones, but they're naturally occurring substances that are found in our bodies that have a regenerative property. So I did some peptide therapies as well, working with growth hormone and something called bioprotective compound and thymosin beta-4 to help really prep my body for as optimal an outcome as I thought I could get.
Yep. So I think, and a lot of it is preparation too, right? Because the two things that we always look at when we evaluate patients for these procedures and kind of determine what the prognosis and outcome is. One is the how the degree of severity of the injury, right? So less severe, usually outcomes are much better. It's really, really severe or end stage, what we call, then it'll be a lot difficult to kind of reverse from that. The second important factor we look at is the overall health of the patient. So the healthier you are, if you don't have any lingering diseases or not taking a lot of maintenance medications, diabetes, things like that, then usually that's better. So the idea that we have here at MCFRM is if we can shore up the patient's health by using supplements, peptides, filling in those gaps in nutrition and in health that you have, then maybe that's going to give you more chances of it to get to work better since we're using your own supplies. Right?
Yeah. So 3 variables to getting a good outcome that we try to control for. Number 1, the patient, just as Dr. Santana described. We try to optimize that patient. And then our lab, wouldn't want to go anywhere else other than one of the facilities that manages cells similar to what we do here using Gray Ledge Laboratories and the processes that have come out of their years of experience and how fast to spin those centrifuges, what centrifuges to use, the processes for separating the cells we want from the cells we don't, and doing so sterilely such that I'm less likely to get any kind of an infection. The trust that goes into that lab is very high, and that when we hand them the bone marrow, they're going to hand us back as strong, as powerful a injectate as we could get from that patient. And that's a really important step that I think oftentimes just gets overlooked. When people say they have stem cells, they're thinking all stem cells are the same,
right?
And they're just not. If you don't process them optimally, and then if you don't count them you don't know what dose you're using, how many cells you're being injected with. So knowing that I had my procedure done using a Gray Ledge lab was a very, very big step for me, knowing that I'm getting a best chance of having an optimal outcome.
Yep.
And then I'll take the third variable, because you don't, I'm sure, want to talk about your skills. But this guy is absolutely amazing at putting them at where they want to be. So, the trust level I have in my partner here, I trust him with myself. I trust him with every one of our patients, that he's going to safely guide that needle, not just avoiding things that I don't want him to hit, like my nerves or my blood vessels, but also putting these cells exactly where they need to go, not just in the disc, but in all those structures that support the disc. It's tedious, it's time consuming. It takes a lot of skill in order to get it done relatively quickly while you're under anesthesia. And his skill level is absolutely impeccable. So I had zero concerns going under. In fact, cracking jokes right up until the very end. And it was a breeze of a procedure for me.
Oh, that's good. I think I was more nervous than you are.
Probably.
No.
I
So we ended up doing the procedure, right? The way we planned it, we're going to target the L4, L5 disc, and L5S1 disc, because those are the most problematic areas you have where you have your degenerative discs. The other discs look pretty good, so we didn't touch them. So the way that we create our treatment plan when we do these injections is we kind of like looking at the spine as a functional unit. So it's a little bit different than your typical pain management approach, where you just kind of find that one area that's responsible for a lot of the pain. In regenerative medicine, it's more of a functional approach, and you kind of look at the spine and the pelvis and the ligaments and the facet joints and the discs all together in the muscles, and how they all interact in that space and how it creates pain and how to relieve it. So in Dr. Navi's case, we treated the discs that we know the problem areas, but we also know that if the discs are affected, the facet joints can also be affected, because if that space is decreased vertically, then more of the pressure probably goes into posterior segments and facet joints. And then in turn, also your ligaments around your spine also gets affected because of that lack of tension that goes away when there's some degeneration that happens. So one of the things that we like to do is address all those ligamentous issues. And then lastly, the muscles around those too, the multifidus, which are the supporting structures, and the stabilization muscles in the lower back, along with the paraspinals. So we treat those too. So it's not uncommon that when we do regenerative medicine procedures in the lower back, we target specific areas, but we usually end up with about 15 to 20 injections altogether, targeting multiple spots in there.
Yep, and that I think is the third and I don't want to say the most important component, but a very significant component in getting positive outcomes. So I guess kind of where I'm at now, my experience afterwards, the day of the procedure, I was fortunate enough to have very minimal pain. I would say in my experience, it's about 50-50 when I'm treating spines. About 50% of people wake up in the post-op day having considerable amount of pain that we're able to manage using different kinds of medications. I fortunately woke up with very little to no pain. And that continued for me throughout my post-op period. Just my regular back pain, which is a nagging pain that would irritate me and make me a little restless at night, a little difficult to sleep, wake up in the morning. Takes me 15-20 minutes to really loosen up. Can't quite bend over to put my shoes on without having to sit down first. And that persisted first couple weeks, just kind of the same pain. And then all of a sudden I would have these days of, wow, I haven't felt this loose, and my back hasn't felt this ease of release of the tension. Boy, I can't remember the last time I didn't have that just tightness in my back. And then the pain would come back, and the tightness would come back. Never worse, just steadily better. I took it relatively easy, but not completely easy the first month, as I tell most of my patients to do. But I did avoid the impact exercises. Good. So I wasn't doing running. I wasn't doing box jumps. I wasn't lifting or medicine balls and things in the gym. So I was really trying to give my back a month. And now, 3 months out, I'm back to everything. And There are fleeting moments here and there where I'll get a reminder that I have back pain, but I can stand up, put my shoes on with one foot again, and I'm doing all those exercises in the gym. Golf season is right around the corner, and anxious to see if my swing speed will be back. I went to the indoor driving range, and my distance, according to the TrackMaster, is back to where it was prior to. I lost about 10 yards on my drive over the past 2 years, and now I was hitting the ball back to where I was 2 years ago, at least on the TrackMaster. So I'm anxious to get out as the weather's changing, get out and start hitting balls again, and see what happens with my golf game.
Yeah, nice. I'm glad to hear the experience that you have is kind of very similar to what I hear with a lot of our patients too, right? So you have that initial soreness and pain for a little bit after the procedure. You're right, like you have that 50% of patients really, really sore, but you have 50% that are like, that's not a big deal. But across the board, usually after about 3 days, roughly to 5 days, the pain goes away. With that initial post-operative pain goes away, and then you're kind of doing better. And then you have these up and down episodes where you have really good days and really bad days, like you explained. And then, it kind of steadily improves where the good days starts to outnumber those bad days. So it's nice to see that, how our patients are describing it exactly how you're describing it. So it's, very similar across the board with our responses.
Yeah, it was interesting knowing that I've talked to many patients who have gone through this, and what they've told me in their own version of what I was experiencing. I was like, it makes sense now. So it was a very humbling experience, but also very uplifting experience, because what we tell patients to expect is quite accurate. And fortunately, I'm one of the patients. I would estimate about 80% of our patients have a similar experience to what I'm having, which has been remarkable. 3 months out, it's not the finish line. Our plan is to re-image with an MRI at 6 months, share those images online with everyone, and continue this story. But we felt like this was a good time to at least share where I'm at, what I experienced, so that you can understand that this clinic really was founded out of a passion for creating a place that we would personally want to have treatment, that we would want our loved ones to go for the treatment. We couldn't find a place like that, so we created it. And I hope that's the feeling you get when you come here as a patient, when you experience the interactions with our staff, the interactions with the physicians, the treatment plans that we come up with you. I hope you really understand that those are our treatment plans that we come up for ourselves, for our loved ones. That's what our clinic's about.
Yeah. It's probably a tough question, but if you want to quantify kind of how you are now versus 3 months ago, how would you say, like, percentage-wise improvements with pain and then your activity level? What do you think?
Yeah, I would say I'm in the 90 percentile.
Wow,
it's not 100%. But it's pretty darn close.
Yeah.
And I feel like I have my quickness back on the tennis court. Like I said, I got my distance back on the golf course. That's pretty much the only two sports I play anymore. Not adventurous enough to try to start playing basketball again or dumb enough. But I don't think it's done yet either.
Yeah.
It definitely feels like there's additional benefit that's still yet to come. I'm hoping those images really back up what I'm feeling. And so far, very, very happy, very pleased.
Good. So you have anything else? I'm going to go through questions.
No, you go ahead and go through questions, and if I think of anything more, I'll share it as it comes up.
Yeah. All right. So we have a question from Ed here. So he's asking, if stem cells are throughout our body, why don't they help heal without a procedure?
Yeah.
Good question.
You want to take it?
Yeah. So that's a good question, Ed. So you do have stem cells all over your body, right? So from what we do in orthopedics, we harvest your stem cells from your bone marrow, which is found in all your bones, and also from adipose, which is from fat, which is from all over your body too. Some people more than others, and there's stem cells everywhere. You're absolutely right. And same thing with your platelets, which are in the blood, which we get their PRP from. The big difference is that your body is constantly healing too, because like your body's always in the state of degeneration, breaking down old tissue, and then replenishing with new tissues. As you get older and as you have injuries, that rate of degeneration supersedes the rate of regeneration. So, and you have to remember too that these cells, these stem cells, these platelets, these growth factors, they have to travel through the entire blood supply to go to all your different parts, all your muscles, all your nails, your hair, your bones, your joints, replenishing all of these areas. So it's being diffused all over your entire body throughout the day and throughout your lifetime. What we do in regenerative medicine is that we're able to concentrate this in a high volume. So what we're talking about is in one volume or 1 milliliter or microliter of volume, we're able to get millions of platelets, hundreds and thousands of stem cells, and then putting it into a large volume. Now we're talking about millions of cells in a fixed amount and billions of platelets in a fixed amount. And we put that in specific areas where you have injuries in. So that really just supercharges your healing process. So we're not really doing anything out of this world. We're just optimizing how your body would heal anyway, and optimizing that effect on specific areas that you need it the most, right?
I think you said it best. It's the difference is hundreds to thousands to millions to billions. It's a dose effect. If you allow your body to try to heal itself, you're going to get a very low dose, because that's just what our bodies are able to get by virtue of natural healing to that area. And if you do what we do, you get a much higher dose. And with most anything in medicine, we know that there is a dose response curve, and such that as you increase the dose, you get a better response up to a certain point. And we're still trying to figure that out. At what point is that optimized? Is that at its peak? We as a society, meaning trying to count cells when we do procedures, track outcomes, and that's exactly what we're seeing is this dose response curve, and we don't seem to have found the peak yet. Just keeps being the more the better, the more the better, the more the better. So that's what we do here. Optimize you, try to get you to create as many as possible, use our Gray Ledge laboratory to concentrate those into as highly dosed concentration as possible, and then use our skills to deliver that dose directly to the tissues that need it most.
Right. And I think that's kind of what separates clinics like us with other clinics too, right? So not all people that say, oh, I do stem cells, I do PRP, is exactly the same, because without knowing that dose, the difference between having 100,000 cells versus 1 billion cells is pretty significant. You can just imagine how much that difference is. And so just because somebody else is saying that they can do PRP, there's a lot more to that than just being able to make PRP or be able to get stem cells.
Yep.
So next question is from David. He's asking, are you able to treat multiple areas at the same time? Example, cervical and lumbar spine together. That's right in your wheelhouse.
I do it all too often. So the Navity special, yeah, we treat a lot of areas at once. We'll do that. Now, what I'm starting to become more conscious about and more cautious about is not decreasing your dose by diluting down to treat too many things at once. So depends on the number of levels, depends on the number of areas. If we're talking about doing a 1 level disc in your spine and 1 rotator cuff, yeah, chances are we're going to have enough cells. We won't know for certain until after the cell or the specimen is processed and we get that dose on the day of your procedure. We won't know that dose until after we've processed your sample, but we can anticipate whether we'll be able to treat multiple areas at once. And if we can, there's a significant cost savings in doing it all on the same day.
Right. So for me, like just a rule, I try not to do more than 2 separate structures at once. Again, just to maximize that effect. Usually when I talk to patients, when patients come in here, they come in because of one primary issue that finally makes them get in the car and come here and see us. And then usually the second one would be like, oh yeah, by the way, I also have this injury. So I try and kind of limit that to 2, just because, again, that dose response curve that we're talking about, you want to keep that concentration high. So we kind of have that discussion, and then we usually come up with the right answer for all of them.
Yep.
Let's see. So the question is the procedure typically covered by insurance? So quick answer is no. Long answer is if you're active duty military on TRICARE, they do pay for PRP for osteoarthritis in the knee and epicondylitis in the elbow. Anything outside of that is not covered by insurance. But we try and optimize what we can with the insurance. So your office visit, we bill through your insurance. If there's any other procedures that you qualify for that's covered within the realm of the insurance, then we try and optimize that as well. But procedures such as PRP, prolotherapy, bone marrow stem cells, adipose stem cells, all these other things that are not.
And I think that answer is going to be someday it will be. The data is supporting, and that we're tracking is supporting that this not only works as well as surgery for certain indications, arguably better than surgery for other indications like meniscus tears in the knee. And now we have that real data that we can share with third-party payers. So if anybody out there is listening and has a third-party payer, most likely maybe a self-insured plan from a larger industrial employer, or a large employer in general, doesn't have to be industrial, but those sorts of plans tend to be more open-minded to, hey, we'd be willing to cover this in lieu of a rotator cuff surgery for you, or in lieu of an arthroscopic knee surgery for you. We're going to save them a ton of money. We're going to save you a ton of time in your recovery. We're going to get you back to work faster. It really is a win-win-win. We have that data. We'd love to share it with whoever might be interested in listening. And a lot of this can be patient-directed. So being an advocate for yourself and trying to help us navigate this system, we have data now that we can share. We have great outcomes that we can prove what we do works on a percentage basis, as well as anything else in medicine that your insurance does cover. So if any of you are out there listening or know people who might have connections, please reach out to us. We'd be happy to share that data and have those conversations.
Yeah, the more we can share this information, share this treatment to more people, the better. So if your employer is open to this option, we show them information and data.
Yeah, that's why we're here on a Tuesday evening talking to a computer, so that those of you that are willing to listen to us maybe can help spread that knowledge.
Okay. Yeah. A question from Derek. What are the limitations of this therapy? Can it help degenerative spine issues? And then can it solve baldness? So the limitations with this procedure is that the two things or three things that we talked about. So having a lab, right? When we talk about that's very important. The second thing that we look at is how healthy is the person, because we're using autologous cells, and so then this means that these are all coming from you. So the healthier you are, the better your outcomes are. If you're very sick and you're frail, it's probably not going to work as well. The third thing is also the severity of the structure we're trying to fix. So if it's mild to moderate degeneration, things like that, it usually responds really well to that. Once you kind of cross over that severe range, so that end stage degeneration or post-surgical with fusions and stuff like that in the spine, and in the case of joints, if it's bone on bone, there's really nothing much that we could do to that. There's some treatments that we can try to see, but we are very transparent up front with you that the chances that this is going to work is going to be really low. And a lot of times for those patients, we recommend to go to have surgery. Unfortunately, that's where surgery makes a lot of sense to do. But if for most patients where you're not at that point yet, then there is a chance for regenerative medicine.
Yeah. And I'd encourage you, even if you're told you're bone on bone, we hear that a lot, and patients get told that a lot. And part of what we do here as part of the evaluation of the office is a diagnostic ultrasound where we can see whether there is cartilage cells there or not. We also look at your MRIs if you happen to have MRIs. So we are very honest in our recommendations. If we don't think we can help, we're not going to tell you we think we can help. We're based on outcomes, and getting good outcomes is number one, patient selection. So we always only tell patients we think we can help them when we truly think we can. And so if you've been told you're bone on bone, don't necessarily think that, I'm not a candidate. It'd still be worth coming in. Let us take a look. Let us see if that's something we think we can help you with. But if not, we'll tell you, no, I think surgery is your best next step.
Yeah. It's a good question from Samantha. She's asking, Are stem cells the best, most effective treatment for cartilage degeneration starting in your 30s?
I mean, if it's a yes/no question, I'd say yes. But the political question is it depends.
Yeah.
Right? There's details in there.
Right.
So
Right.
simple answer is yes. It's a great thing to think about before you think about any other cartilage restoration or any kind of surgical removal of degeneration, clean outs. Let us take a look. Let's see if we think we can stabilize the joint, rebuild some of that degenerative tissues before going the traditional surgical route.
Yep. Yeah, it's a complicated question, right? So usually in your 30s, there's other reasons why you have osteoarthritis and degeneration at a really young age. So there might be some other underlying issues on there, more to explore. But when I kind of talk to patients in general about regenerative medicine, the options of prolotherapy, PRP, or stem cells, it's kind of like a hierarchy, right? So the prolotherapy gives you that inflammatory response, but essentially it's a weaker response. So you need to do it more frequently to kind of build up to a better outcome. The next step to that is PRP, where you have a stronger response because we're actually harvesting the parts of your blood that actually starts that healing cascade in there. So it's a stronger response with healing. And then stem cells are kind of on the top of the hierarchy because it's a lot stronger response that we're able to create on there. And we're not restricted to, we're not really restricted to, because we can use your bone marrow stem cells and also your adipose cells. So we won't have an issue with volume and things like that. Okay, so the other question from Jeff is, do you do shoulders? Yes. And also stem cell extraction from the bone marrow, and the whole process is done in one day?
Yes. So I can attest to that bone marrow aspiration process. I did not have any anesthesia. The numbing medicine, pinch, burn, by far the worst part. After that, it's a lot of pressure. It's like I describe it like somebody putting a suction cup on your back and trying to like lift you up by that suction cup. But it's just that deep pressure, not sharp pain. Had mine done, did a couple other procedures while my blood was spinning, and then went under for the re-injection myself. So the entire time to show up, time to leave, about 3.5 hours.
Nice. Yeah, and that's one of the things that we want to be able to use your orthobiologics as fresh as possible. We want to make sure that it's done the best way, and that's the safest way to do it, and delivering that directly. Good question from Scott. Do you bank your stem cells and use a stored amount from a couple of years back, or were they from a more recent draw? Second part, did you talk about banking stem cells from early as possible, and if they are more effective in treatments? So did you?
Yeah, so I did. So I've had 2 bone marrow aspirations. First one was strictly for banking. I did that at age 39. I'm 45 now. And the concept there, it's a bit of a gamble. It's an investment. How about that? Rather than a gamble, it's an investment in your future, in the future, what this science is going to bring. And that investment is that younger stem cells are going to perform better than older stem cells, and your stem cells are going to perform better than a donor stem cell. Time will tell whether that investment pays out. One of the technologies that needs to be able to be developed is something called culture expansion before I'm going to use my young cells. So that's 39-year-old cells that I banked, I did not reuse for injection into my 45-year-old spine. And the reason is I still have good cells. 45-year-old cells are still good cells. The ones I banked right now, I can't culture expand them and re-inject them in the United States. That is against the FDA's 361, 351 guidelines. So 1, we don't want to do that. And 2, I didn't want to ship them overseas and have them culture expanded and re-inject them overseas because it's really expensive. Right now, culture expanding is about a best guess I can get from the different companies I've called about a $60,000 process. Whew. And that I believe that number is going to come dramatically down. When I was in late high school, early college years, the human genoming sequence was a big deal, and that was a couple $100 million project to sequence a genome. and now you can get it for $300.
Yeah.
So technology will take over. I'm very confident that cost will come down to the point where it's extremely affordable. And that's where I'm hoping then to be able to utilize my 39-year-old cells, culture expand them, and then reuse them in the spine's not getting any younger. Well, maybe it is now, but it's not getting a lot younger. I'm sure I'm going to need a repeat procedure at some point. And then maybe when I'm in my 70s or my 80s, I'll be looking to use my 39-year-old cells that I'll now have culture expanded and have an infinite supply of, rather than my 75, 80-year-old cells.
Yeah. And the other thing, too, you make a good point, like at 45, your cells are still pretty good. And the other thing to realize also, when we do extraction on the same day, we're talking about viable live cells versus cells that are, frozen, and most of the times they're not viable. So there's a big difference there too, and that's one of the reasons why umbilical cord cells and stuff like that tends to fall short with regards to orthopedic applications. For orthopedic applications, and it's still better to use viable live cells.
That freeze thaw process is very hard on live cells. Without being able to culture expand them and then use them while they're fresh. I'm 100% in agreement with Dr. Santana that you're getting growth factors, but you're not getting cellular function. And I still think cellular function's going to be greater than any concentration of growth factors alone. Given equal doses, it's best to use the live cells that have the growth factors as well as live cellular activity.
Yeah, and that's kind of like what Jeff's question is. He's 70, he's asking if he still has viable cells. As long as you're living and breathing, you have viable cells. The oldest patient I treated was 89. So
95 for me.
So you always have these stem cells. Like I said, as long as you're alive, your body still creates tissue. So when you're creating tissue, you have stem cells, and you use these cells. They still repair. Your hair still grows. Your nails still need to be cut. So you still have cells in your system. It's just a matter of harvesting these cells and making sure we're able to concentrate them in a volume large enough to have a response. It becomes tricky now when we're not getting enough of that. But the nice thing about doing the way that we do it, and our lab being able to analyze these cells before we reinject them and know exactly what the number is, if the number falls short of what we want, we can always go back into the source and get more cells from there. We can supplement and augment that with PRP if we need to. There's other treatments that, doing this for a while, we've know a lot of ways to kind of get around problems with doing these procedures with our experience.
And a point I'd like to make, chronologic age, meaning what year were you born, is not the same thing as biologic age. How old are you? How close to death are you, if you want to think of it that way? There's plenty of people in their 50s who are biologically much older than people in their 70s. They're closer to death because they've just not taken care of their bodies, or they got bad genes, or whatever the reason. But don't focus on your chronologic age. What's more important to us is how biologically active are your cells? How healthy are you?
All right, I think we're
I think we should probably wrap this up.
Yeah.
We're a little longer than normal, so those of you that have stayed in, thank you for holding the attention. If we didn't get to your question, we apologize. Would love to be able to reach out to us via phone or via our internet. We have a support at mcfrm.com. You can find that on our website, regenerativemedicinemichigan.com, or give us a call, 248-216-1008. Really appreciate everybody tuning in and the great questions, and listening to me talk about myself. I can get a little old.
No, it's good. All right, thanks. Good night, guys.
Thanks, everybody.